The last but not the least one is Mr. Steven Wanyee. So Steven, please present your paper.
Thank you very much. I hope you can see me and hear me clearly. So my name is Steven Wanyee, calling in from Nairobi, Kenya. First and foremost, just want to thank Tom and the CED team, and also my good friend Derek Ritz, who introduced me to this team. And today I'm going to share about, it's sort of like a broad topic, and I'm going to share about digital health workflows in the time of COVID. I'm going to make specific reference a lot of times to my country, Kenya, where I'm calling from, but also my references also are applicable to many countries in Africa, which are very similar in a lot of, especially sub-Saharan Africa. So this first slide just shows, and I'm sorry it's not as clear as I thought it was, but this first slide basically shows sort of the healthcare system, typical public healthcare system. And if you can read from the bottom left, that basically shows how the typical health system is, public health system is structured in most countries like Kenya. Everything starts from the community level, where you have a bunch of households that are collectively called a community unit. They tend to be about 5,000 or so, and those are linked to a health facility. So this are that goes to health facility. The idea here is that it's really for referral purposes and to support continuity of care. And then typically what happens is that a bunch of facilities are then clustered or aggregated around a sub-community, sub-county, sorry. A sub-county is really, it's a political geographical jurisdiction that is governed right from the national level. And then up above the sub-county, you have a couple of sub-counties which belong to one county and then to the national government. So this is the typical sort of layout of a country like Kenya. And therefore the health system is really treated that way. And the reason I'm showing this slide is just to show you how data flows back and forth. And this is also the same way that in these times of COVID, the digital health solutions that are being implemented and developed are also deployed. And therefore the data flows follow the same pathways. Next slide, please. And then this next slide, it's a little bit old. It was really developed by the Disease Surveillance and Response Unit in Kenya, of the Ministry of Health in Kenya, a couple of months after COVID landed in Kenya, probably in the first quarter of last year. And it just shows you in sort of a very simplistic way how the surveillance system was put together. So reading from the top left, where the idea then, and I would say this is still pretty much the case, the ministry established a case identification and notification system where alerts for COVID-19 would come through from different channels. You know, either this would be from the community, points of entry into the country. And in terms of digital health, there are systems that were built immediately after COVID struck. And those are still currently in use, mostly utilizing, what do you call it, mobile devices. And then if a case was found to have signs and symptoms for COVID, and of course there's a protocol that is, you know, drawn from WHO and domesticated, then that would trigger a case investigation. So you go to 2A and isolation. And, you know, ministry has a rapid response team of surveillance officers who then were using well-structured forms, you know, case investigation forms, and also digital health applications that are also rapidly built around the same time. And they have been refined and are still in use. And those are either running on mobile devices, but the ministry has also, with its partners, gone ahead to basically refine and improve electronic medical record systems to also support that process. And then, you know, the ministry has a lab network with the lab information management system that then the results would, you know, the orders will be sent to labs which are accredited to conduct case investigation. Diagnostic, for case investigation for COVID, and then those results will be relayed back. And I'll show you in a few slides downstream how that looks like. So then if the case turns positive, so this is still part of sort of step 2, that would trigger contact management. Again, typical of what most countries are doing, track and trace. So this will be followed. Again, there are a couple of digital health solutions that were actually developed and that are used for that part of the process. So the contacts would be followed, and these contacts would be encouraged to either self-register or self-report, or they would actually be, they'll be traced by the surveillance officers. So one of the most popular applications, digital applications, is called Jitenge. Now they have Jitenge Plus, and Jitenge is a Swahili word for isolate. That's exactly, it's a verb for isolate. And so this is the official Ministry of Health system that is currently in use. So then the third step, again, obviously oversimplifying this process, would be quarantine management. So again, following the protocols that are established by ministry, there will be a process of determining who needs to be quarantined. There are facilities for quarantine, data is collected, the cases are followed up until exit of that part of the service, and there's a bunch of systems there. And again, you'll notice that the most common system across this entire process is Jitenge Plus. So this is really sort of the Ministry of Health in Kenya's system. And again, this process really reflects a lot of what most countries, particularly in sub-Saharan Africa, are using. And then lastly, of course, will be strategic information management. So in this, for those of you who have been experienced in Africa, you probably know DHIS2, District Health Information System, that was developed at Oslo University, is used in most countries in Africa for health management information system, which basically means managing aggregate data at public health level. So this basically shows you a system that very sort of making reference to Kenya, but can also be, it's generic enough that it can be applied to many other countries in terms of how their COVID national response data systems and workflows have been working. Next slide, please. So this slide basically pulls out of the previous slide the laboratory system. Of course, there's been a lot of focus on lab, just for purposes of determination of the diagnostic process to determine who's a real case. And so Kenya, like many other countries, currently has about maybe 50 labs that are accredited to conduct COVID tests. And these are spread all over the country. Uganda, for instance, has about, as of the last time I checked, there were about half of those. And so many countries have gone ahead to accredit this. And again, some of you, if you've worked in Africa and similar parts of the world, the National Public Health System network is very popular. And in Kenya as well, we have that, where these labs have met all the quality control assurance and all that, and they have the right personnel capacity and stuff. So similarly in Kenya, they did the same thing as well. And so if you read this from the middle part of the slide, there'll be a bunch of labs that then are running these tests. And they are communicating with the surveillance team, using the application that I mentioned, Jitenge Plus or Isolate. And similarly, this lab would also send the data to the National Public Health Lab, which is also for QA, quality assurance, but also it's required by law to send all the data here before this data publicly released for determination and all that, and some legal accountability as well. And then EOC stands for Emergency Operations Center, which has been set up in the Ministry of Health, basically for all disease surveillance and response. And they have a huge dashboard where they look at the status of public health and all that. Then through APIs, this connects to external systems, which these are really point of care systems, basically where the patients would interact or touch the health system. Next slide. Next slide, please. Yeah, so this I've mentioned this basically in the two slides before this, and this just tries to summarize the systems that are in use in the country. The point to make here is that these systems are open source, and I think given the topic of this session today about innovation in times of COVID, one of the biggest innovations I would say in Africa, in Kenya and other countries in Africa, has really been the use of global goods. Some of you might know what global goods are, but basically they are this collection of digital health applications that have been used by many organizations for the last, kind of like 30 years or something. And they've been shown to have, to basically meet all the good principles of developing software solutions quite well, making sure they're sustainable, developing the user, all these principles for digital development. And so a lot of countries in Africa, including my own country, we use global goods. So the agility and our ability to innovate and really leapfrog, as one of the previous presenters had mentioned, is real. And I would say that's one of the main messages I wanted to bring out of that slide. This slide and the next two slides before I wrap up basically shows just a snapshot of the dashboard. This is just a tabular report or line listing of quarantine records. So nothing much, just wanted to give you a snapshot of that. And this is out of the emergency alert and reporting system, which is owned by the ministry in Kenya. And most countries have that. And this is my last slide that basically shows cross-border health in times of COVID. So, and I wanted to emphasize that, again, going back to my comment about global goods, one of the very popular health information exchange is called Open Health Information Mediator. And this just shows two countries bordering each other, Kenya and Uganda, that have actually implemented this. I was part of this project. And again, if you don't want the details, I'll be more than happy to share this. I know we're running out of time, so I'll save a bit of time for Q&A. Thank you very much, and back to you.
Thank you, Steven, and thanks everybody else who spoke. before and provided insight to really a very broad range of topics but that in the end all come together centered around the one question: how can we improve care delivery and care quality and access to care to patients in our respective health systems, especially in challenging times as we've just been through. So with that, again, thank you everybody for the interesting presentations and their contributions. I would like to open up for discussion. So feel free, please, to either unmute yourself and voice your question or type a question in the Q&A.